Well, hello there, and thank you for tuning in to this week's edition of Telile 24/7. I'm your host, Adam Cook, and this week it's not a typical show for us. We're going to spend the next hour sharing highlights and conversations from a community consultation carried out by Nova Scotia's Department of Health and Wellness earlier this month in Port Hawkesbury. It was part of a province-wide tour being carried out by Nova Scotia Health Minister Michelle Thompson, several members of the Nova Scotia Department of Health and Wellness and the Nova Scotia Health Authority, and local MLAs, including the MLAs that serve us here in the Strait area, to help people give a more accurate picture of what healthcare looks like in our area and what gaps need to be filled so that people can get the medical treatment that they need. So we're going to spend the next hour looking at footage from that community consultation. We would like to thank at this time Nova Scotia's Department of Health and Wellness for providing us this footage for free so that we could share it with Telile viewers as a public service. You're going to see some additional footage on this week's edition of Roundtable, our sister program. But to begin this week's edition of Telile 24/7 and an hour's worth of highlights from the community consultation on healthcare in Port Hawkesbury, here are some opening remarks by the MLA that serves Port Hawkesbury and the riding of Inverness, Deputy Premier and Finance Minister Alan McMaster.
It's nice to see a big turnout here in Port Hawkesbury tonight. We were in Inverness earlier today, and I want to acknowledge we have a couple of councillors in Port Hawkesbury, Huey McDougall and Mark McIver. I see them sitting there, and I was scanning the room. I don't think there's any others at the moment here, but and MLA Trevor Boudreau, who is no stranger to Port Hawkesbury and is not too far away in Richmond. So welcome, Trevor. Michelle Thompson has roots in Middle River. She's been a nurse for 30 years now, and she represents Antigonish in the legislature. A great background to have as a health minister. She's been there, she's seen it all. So welcome, Minister Thompson. We have Karen Oldfield, who's the CEO of the Nova Scotia Health Authority, and we have the Deputy Minister of Health, Janine Lagacé, who's with us as well tonight. So, and there are also at the back of the room, you may have met some of them, a welcome to all the visiting health staff who are here tonight. It is great to see them on the ground. They're here to hear your thoughts, and I think it's important for people to get out into communities and listen, and that's what tonight is about. So I could say some more, but this night is about what you have to say. So I'm going to cut my remarks short, and I'm going to let you continue. Have a good evening, folks, and I hope you get something good out of tonight's proceedings.
Good evening, everyone. My name is Michelle Thompson. As Minister McMaster said, I'm the MLA for Antigonish. I am the Minister of Health. I'm a graduate of CEREC. I graduated a while ago. I graduated in 1990 from CEREC. I came up for a year to finish my grade 12 year, so it's a little bit familiar to me. So I'll just give a bit of a recap. We certainly ran a platform to fix healthcare. It resonated with Nova Scotians during the last election. And when we formed government, we made some quick and bold steps to address the healthcare system and put it back on its feet. So one of the things that we did, we have a new health leadership team. So prior to this current model, Nova Scotia Health and Department of Health and Wellness ran parallel, to be generous. They didn't have a lot of opportunity or didn't seize the opportunity in the past to work together. But now we have a health leadership team that is well represented by Department of Health and Nova Scotia Health. So policy and funder now works with the operator, and every week they sit together as a team and they make decisions for the system, which before we often hear the word silos, and that's what that meant. That these folks were running parallel and didn't often know what the other one was doing. And so it was really important that we have a health leadership team that's experienced and agile and is able to address situations as they come up in a timely fashion. And so we've had that for the last 15 months, and it's enabled us to do some things in a very quick fashion. We also went around and talked to healthcare workers. We started in Neils Harbor and went all the way to Yarmouth, and we talked to a lot of healthcare workers about what were they experiencing. We wanted to affirm what we had said in the platform, that it resonated with healthcare workers, that we heard directly from them what they were feeling and what their solutions were. What did they say? I said, you sit around the coffee room and you say, why don't they just whatever? Well, we're they. So what could we do to make your work environment better? What could we do to be more responsive, more reliable for Nova Scotians? And so from those comments and feedback in those sessions, we built Action for Health, which is a strategic plan for our healthcare system that we have, and it's accountable. We have a website that takes metrics. We're growing and maturing in terms of how we measure, and that's reportable to all of you, available to all of you. So we continue now to come out into community, tell you a bit about the progress that we're making, areas where maybe we wish we were making better progress, but we still feel that we are addressing in a certain way, but also to hear your ideas. What does your community need? What are some things that you think would work here? Maybe you're wondering whether or not we're doing something or trying something, and we want to know what some of those things are. We know there's a number of issues in healthcare. We know we have a big hole to fill back in, but we are committed to doing that. So tonight, while we want to answer your questions, we also really want to stay solution focused and hear what are the things that you think or you wonder about whether or not we're addressing. So I look forward to the conversation. I look forward to your suggestions. It's going to be all hands on deck, your hands, my hands, our hands on deck to address the issues in healthcare. And so I really look forward to hearing from you tonight. So thank you.
Thank you very much for being with us this evening. I think we're on our 11th of 12 stops, and we did 12 stop of 18. And we've had great conversations in every community that we've visited so far, and we know that we will have another one great one here tonight in Port Hawkesbury. Just picking up on a couple of things that the minister said, we're very proud of Action for Health, our strategic plan. And I think that what I would like to emphasize about it and what we'd like to talk to you about this evening and hear from you is that we know there are a number of you who would be here with us tonight who've probably waited much too long for certain services. You may not have a primary care provider, and you all probably have some kind of a story that you could tell us, and as the minister said, probably a potential solution as well. But to get to those solutions, we can't just keep doing the same thing that we've been doing until now, that we can't tinker around the edges anymore, that what Action for Health we hope will do for us is to bring us to a transformation to a world-class system. So that's really our commitment to you through Action for Health, is that we want to have a world-class health system for you and for all Nova Scotians. So we've set up the format as question and answer, but really we want to have a discussion with you, a back and forth dialogue. We've learned something, as I said, everywhere we go. We're not waiting until the end of all of the sessions to start acting on things. Most mornings after, Karen and I have a conversation and there's something that she's going to follow up on or something that I'm going to follow up on. So please know that what comes of our conversation tonight will be acted upon as soon as we can. So I look forward to the discussion.
It's all about the people. And it really doesn't even matter what sector. But right now, in the healthcare sector, it's really all about the people. And so I'd like to start by just having a show of hands for the healthcare workers here in the room, just so we know who's here. Past and present. So we got a few. Okay, here we go. Now we got some hands and a lot in the back. So big show of hands in the room. And I would like to start by saying thank you. Thank you to those who are in the system currently. Thanks to those who devoted probably many years of your working career to the health and well-being of Nova Scotians. It's a challenging time. And, I just remind people that almost 3 years ago was the front end of the pandemic. And it's hard to believe 3 years have gone by this quickly. But at the beginning, the healthcare workers in the room and their colleagues were the heroes. And people were banging the pots and waving flags and giving out Tim Hortons cards, and somewhere along the way that just seemed to stop. And now it's a completely different story. Our healthcare workers are are seeing, they are frustrated, they're seeing frustration, and folks are not always as patient and kind as they need to be. And so I just want to acknowledge again the work and the effort, and thank you for what you do. Thank you. Yes, thank you. So with that, I'd like to ask a couple of our local leaders to come up here and introduce themselves. You can decide, Brett, who you want up here. We got a little team there. They were introduced themselves last night in Glace Bay and this afternoon at Inverness, and I think it'd be great to do it again tonight, just so you can see who they are and know what they do and what they do for you. So over to you, Brett.
So good evening, everyone, and thanks for coming tonight for the conversation, and look forward to the discussion. Brett McDougall. I'm a registered nurse. All my years of taking care of patients was in the emergency room setting, but I've since moved on to management and administration. The last number of years, I was the executive director of operations for Eastern Zone. Most recently, taken on the position of vice president for Eastern Zone just in the spring there. So happy to be helping to support our teams and working with our teams in Eastern Zone. So that's Antigonish, Guysborough, and Cape Breton Island. From North Sydney, born and raised there, and just probably live about 10 kilometers from where my house was and my family when I grew up. So really, we're really interested in trying to, as Karen, Janine, and Minister Thompson had mentioned, look forward, not really look back in the rearview mirror here. We know there's a lot of challenges that have built up over time, and we're looking for how do we move forward and look for solutions and improve the system. But it is going to take some time and some effort and some patience. I think we have a great team here in Eastern Zone. We're supported provincially with counterparts in the other zones and with Department of Health. So I think it's the right steps forward. Working in tandem together versus in sort of separate parallel paths. So a lot of opportunity, I think, going forward in the future. Obviously, the Strait-Richmond facility is a vital part of our system here in Eastern Zone. It's a sort of a key pillar, cornerstone. And I know most recently up in that area in the last probably 6-8 weeks with the support from the community, the foundation, Joe Shannon, in relation to the renovation. So a huge thank you to everybody from the community in relation to the support to that facility, and then the contribution from Nova Scotia Health and the province. Walk through. I think the place looks great. It's refreshed, more functional for the team. And I think it will help going forward in the future. But I'll stop my ramble here and hand over to Dr. Bryan.
Thanks, Brett. My name is Don Bryan. I'm the medical executive director. I'm an orthopedic surgeon. I've been working. Brett didn't say the years, but Brett and I basically met 25 years ago in the emergency department. He was an emergency department nurse. I was an orthopedic surgeon. And it's interesting that we're both here today. I think we're both here today for the same reasons. I'm still a practicing orthopedic surgeon. I do have attachment to this community and to this hospital. When I first came here 25 years ago, I wanted to get out into the communities. I was coming here on a regular basis. I was coming here once a month for years and years. I've got to know a lot of people here. Some people travel to Sydney for surgeries, for treatment. Whenever I walked in the door here, I was, oh, now that you're here, would you mind looking at this or looking at that? So it was a great opportunity. I did take a leadership position, and unfortunately, that took up some more of my time, and that's why I stopped coming here, but I had a large group of patients. So this place is important to me, and I know the situation it's in right now, because I did see it 25 years ago when it was alive and vibrant, and I do see a change now. That's concerning. That's why we're here today. That's why I took this position, to get the physicians and the doctors. That's what I represent in our Eastern Zone, is the physicians and the doctors. But it's come up a couple times already, is you know, the physicians and doctors, we do have a seat at the table. We do, and it is a team. We do not do things on our own. We see what needs to be done. We are physically treating the people, but there's nurses, there's business people, there's administrators, there's very smart people in this group, and I love to see work. I love working with them because it is a team, and we are doing some good work, and we have an opportunity now with this government to actually make some steps. The healthcare system, it is not in great shape, but I think this is a great opportunity to do something, and so I am excited about that. I know where we are today. I know where Strait-Richmond Hospital is today and the community is today. I want to hear what you think, what you know. We're here to listen, and it's great to see this many people out here on Friday night. Thanks.
Hello, my name is Glenn Cox. I'm the Executive Director for Community and Rural Health, and also have responsibility for a number of allied health professions such as pharmacy, lab, and DI. I'm a pharmacist by training, and as Dr. Bryan has mentioned, I also worked throughout the Strait-Richmond Hospital probably about 20-some years ago when it used to be under the old Eastern Regional Health Board, so worked a lot with some of the staff members, met some that are in this hall today. And we know we have some challenges. I was at the meeting with, the foundation meeting when we opened up the Ruth Shannon Ambulatory Care Clinic. Very positive news, but we do know we have some challenges, and we heard that at the meeting, and we're working hard to get the hospital back to where the community needs it. I think that was made clear at that meeting. This is a very integral part of the community, as well as the hospital and other services such as primary care, physicians. So just that we're committed to getting that back, and I want to mention that. I also do want to recognize Andrew Heighton at the back of the room. He's the Director for Integrated Health, working closely with the facility here and the staff so we can meet some of those challenges and get us back to where we need to be. Thank you.
Good evening. My name is Michelle Podesta. I'm the Executive Director for Acute Health Services and Primary Health Care across the zone. I've been telling everyone I'm still a new Cape Bretoner. My family and I moved here 2 years ago from just outside of Vancouver, looking for a quieter life with our kids. And I think when we first moved here, our kids weren't so sure, but I've been telling everyone our 16-year-old tells us that it's the best thing that we've ever done for her. So that's good news, and really proud to be part of this team. I just want to acknowledge Gina sitting over in the crowd. One of the things, the Deputy Minister said earlier was, we have to do things differently. And one of the things that we've been really looking at, more so from a primary care lens, is how do we do things differently? I think our trying to recruit nurse practitioners and family physicians and our allied health to support a collaborative practice, we need to be able to do some things different. And we've really been working with Cape Breton South Recruiting for Health, and really just trying to be innovative. So really excited to be here this afternoon, or this evening rather, and looking forward to the discussion. Thanks so much.
So I'm going to start with a submitted question, actually. This is how we get warmed up. And it gives you a flavor of the kinds of questions that people have sent in. So this one is, what is the Nova Scotia government doing for retention of frontline healthcare nurses, physicians, allied health, who have 10 plus years of experience?
Oh, where would we even begin? Okay, retention. So it's a broad topic. I'll jump in. Usually when I talk about retention, I also go to recruitment. But if we were going in order, it would have to be retention and then recruitment, because the folks that are in the system today have put their blood, sweat, and tears in, deserve to be respected and valued and all the rest of it. So we do a number of things depending on what particular healthcare worker that we might be talking about. A lot in many of the sessions that we've had, it comes up quite a bit with respect to nurses. So I'm just going to maybe start with nurses. It's tough to be a nurse these days. Really tough and very competitive in the marketplace. So particularly our younger nurses can go anywhere they want to go. They can go to any province. They can go to Texas. They can be a travel nurse. They can go on a cruise ship. You know, there's so many opportunities because everybody needs nurses. And so what I have said over the last few town halls to our nurses is that we're heading into collective bargaining with our nurses in Nova Scotia. I have a niece, she's 27. She's a second-year nurse. She's a cardio. She works in the surgery in Halifax. And there's not a week goes by that she doesn't say, you know, in Newfoundland, they're paying this. In PEI, they're paying this. Wherever. She makes sure I know. And actually, that's helpful. And I do like to understand, you know, what she and her friends are talking about, because they are the future. So as we go into collective bargaining, I think it's very important to note and to understand that if we look at Atlantic Canada, we're the biggest province, we have the biggest hospitals, we have the biggest population, we have the most experienced healthcare workers, really, because we do have the biggest teaching hospital in Atlantic. And so, you know, all of our healthcare workers, and in particular, you know, our nurses, need to be fairly compensated. So compensation is an important part of retention, but it's not the only thing. And I want to, you know, talk about the fact that the lifestyle, to be a nurse, particularly right now, it's very difficult. I think here in this part of the province, probably even harder, because we need people. So folks are running short. They are short-staffed. They're running hither, thither. They're being redeployed. Any number of issues. And so part of what I think we really need to do is find ways to, what's the best way to put it? Nobody can work like that all the time for their entire career. You just can't do it. So we've got to find ways where nurses and other professionals are able to get a break in the action. So, you know, this is conceptual only, but finding ways where they could be cross-trained so that maybe one part of the job's a little harder and one part of the job's a little easier, but it kind of evens out, just as an example. We have to find ways to break through that work-life balance, because we've got nurses right now who, they go home for supper, say hi, go back to work. Go home, walk the dog, go back to work. Like, this is not a sustainable lifestyle, okay? That's the bottom line. So on the retention, the best way we can help them is to get people, which goes to the recruitment.
Right now, we do have so many vacancies that people can actually kind of work wherever they want. So it's and so we need to reduce our vacancies. And so one of the things that we're doing, we need to grow our own workforce. And so I've said at every session and any chance I have an opportunity, if we want to keep our youth and young people and mid-career folks that are looking for a change in Nova Scotia, healthcare has any and every opportunity that there's available. So when we look at folks needing to go away to work, we don't, if you want to work in healthcare and you think it's for you or your child or your grandchild or your nieces or nephews or whoever, there is work here. And so we really want to recruit. And I know we hear a lot of negative things in the media sometimes about healthcare, and I don't want to discredit that at all. But what I do want people to know is that, you know, healthcare, nursing has been a very, very meaningful and noble career for me. It has been, you know, what I've loved to do. And I think there's lots of opportunity, and there's an opportunity to be with people and help people on their best and their worst days. And so I would just like to get that message out that there is some tough days, but there are some really wonderful days in healthcare, and I think our youth need to know that. We do have the Office of Healthcare Professional Recruitment, and they have a keen eye in working with Nova Scotia Health on how we bring all different folks to the profession. So we've increased our ability to train through our university and community colleges. We've got an MOU with an organization called Michener Institute that will help us train some allied professionals. We also want to look at where there is a career ladder in a certain profession. So as an example, paramedicine. If you're a primary care paramedicine and you want to become an advanced care paramedic, and then or a critical care paramedic, we want to make those pathways really clear and easy to you so that as you maintain or gain your competencies, there's an opportunity for you to move on if that's what you want, so that we want to continue to invest. We also need immigration. In migration, so if there's people that want to come home, we need to make the credentialing process easier for them so that it's easy for them to come back. And similarly with internationally educated graduates, we need to work with our colleges to make sure that folks can come here, that their credentials are recognized, and that they're able to work to the fullness of their ability. And sometimes it's people who have grown up in a different part of the world, but we have a lot of Nova Scotians who have trained internationally, particularly physicians, who have trained in Ireland or SABA or Australia, and we need to make sure that they see a clear pathway for them to come home. And we've been able to work with their residency program to identify that we have Nova Scotians who have been trained abroad, and we want to identify those folks through the matching system to make sure that there's opportunities for them. So there's a number of different things that we're doing, and they're going to take a little bit of time, particularly if we're going to grow our own. And the beauty of bringing people in who are immigrating or in migration is that instead of just having novice practitioners all entering at the same time, we actually have mid-career people, that have some years experience who are coming and bringing that, because one of the things that we need to do for retention as well is to support our novice practitioners, because it can feel quite overwhelming. I remember it is quite overwhelming in the beginning, so making sure that we have we have the right people in place to support our novice practitioners. So those are some of the things that I would point to.
This time last year, the Premier announced that all graduating nurses would get a job offer to work in the province here for the next 5 years. So that's a huge effort that we're making to try to keep our own graduates here in the province. Also for continuing care assistance, that this year the province is paying the full tuition for people who want to go to get their continuing care assistant qualifications. And we saw the class number jump. Correct me if I'm wrong, Minister, I think we had 200-ish last year, and it went to over 1,000 this year. So it was it was an excellent move, and we're really looking forward to those folks graduating. And then just the last thing I'd like to speak about is community. And on the physician recruitment side, we announced recently that there's a $2 million fund for community groups to access to assist in recruiting physicians. So working with local community groups, perhaps your foundation, and the recruiters at Nova Scotia Health to bring people into your community. So that fund was available for groups to apply to now. I think it's closing shortly, but I think some early into December. And then the last thing on community is, we like to say that all of you here are recruiters and people who can retain workers for us, because we know that people setting roots in their community and the relationships that they make within the community is what really keeps them there. So just really important, if you know that someone new is coming to your community, a new practitioner, whatever they may be at the hospital or in one of your primary care clinics, that please try to make them feel welcome, and because that's what we know is definitely what's going to be able to keep them.
I guess my question is around the Strait-Richmond Hospital. I know that the emergency department has been closed probably more often than it's been open, and I know that's not just doctor shortage, it's also a staff shortage. I'm wondering if you've looked, I know there are policies in place which are required before you can open an ER, you have to have that standard met. But when you look at some older people that may have heart attacks or everything, having to go all the way to Sydney or all the way to Antigonish, is there a way that maybe at least for an interim period, that some of those standards could be lowered just a little bit to offset maybe the danger on the other side of something having to be transported an hour and a half to one of the main hospitals? Just wondered if that's something you might have considered.
I'm Andrew Heighton. I'm the Director for Integrated Rural Health. So Strait-Richmond is part of my portfolio. So working closely with Rose at the site. So the emergency department, we have one physician currently that's providing care for the emergency department, and Dr. Hansball provides 48 hours of coverage. So we do have 2 full days out of the 7 that we have a physician to provide coverage for. So That's one thing. Nursing-wise, as you mentioned, some closures are due to nursing because we don't have emergency-trained nurses in order to open up the department, so we can't provide the level of care we need to have an emergency department open. So we do our best to modify and shift the schedule, and the staff is phenomenal to change their shifts. And as has been mentioned here, they'll come in and do extra shifts, but sometimes it's just they can't do that extra shift, and they want to stay home and walk their dog and see their kids. So those things do happen. Unfortunately, we do have to close or not open the emergency department for that time. So those are two of our staffing things we're working on. We do, I will say, in a positive note, I know we have two registered nurses coming in the new year, spring. We have a couple LPNs. So we are seeing positivity with recruitment to the site, working hard there. But also with the emergency department, there's other things we're working on with virtual care. Jan Summers' team with the virtual ER. We did do a pilot at the site with that team, and they are coming back, so we were able to hire ACP and a ward clerk that will be able to work and provide virtual care through, at the St. Sorry, I got a cough and a cold. At Strait-Richmond, so we're working on providing virtual care, so when Dr. Hansball is not there, we're looking at to see if we can offer this virtual service for emergency, less urgent needs during the days that we don't have a doctor on site. We'd have a doctor on an iPad. They could be in Truro. Dr. Tanya Sullivan is working with us. She'll provide some coverage as well. So we're just working through that process now to be able to provide that out of the emergency room here at Strait-Richmond. And as well with the EHS thing, we do work with EHS a lot. We do work with EHS, and there is they have a physician, and EHS can speak to this better than I can, but we do work with them a lot, and we do have opportunity to provide care and stabilization if needed in situations. But again, if you're having a stroke or a cardiac arrest, you're not coming to Strait-Richmond anyway. You're going to go to St. Martha's for a CT scan or the advanced care that's there, ICU, cardiologist. So if that was the case, you wouldn't be going to the Strait-Richmond, you'd be bypassing and going to St. Martha's or the Cape Breton Regional anyway. So in those cases, it wouldn't matter if we're open or not. You'd be going to those higher level acuity hospitals. So, but we are working at how can we provide more opportunity to accommodate lower acuity or urgent treatment at Strait-Richmond that we are unable to offer 7 days a week now. So we are working on those things through recruitment and other modalities of care.
Thanks, Andrew.
Yep.
I think the other part of your question is around EHS, and we have really good representation here tonight. Jeff Fraser works with the Department of Health. He's an experienced paramedic, and I do want to acknowledge Kevin McMullen, who's the president of the paramedic union. I always get the letters mixed up, Kevin. I apologize. So I just say the union. And so we're grateful for our evolving relationship, trying to work directly with those who are at the front line to address some of the issues in the EHS system. So grateful for both of these fellas. And we'll turn it over to Jeff to talk about some of the work we're doing with the EHS.
So there's no doubt we have some challenges that we are facing head on in the EHS system. I've worked over 3 decades in the system and left and came back I was an operator, came back as the regulator. And so I hit the ground running about 7 months ago, and we are full bore trying to make the adjustments to our system that need to be made. So we've got some capacity challenges. We've got some staffing shortages that impact us, and there's no doubt things like closures increase our time on task, but we are continuing to make these changes. And one of the changes I'll share with you is, I won't throw a bunch of numbers, but I want to throw a few out there. About 70% of the patients that we see in EHS are what we consider to be low acuity. So some of these folks need to go to the hospital, some of them need a care plan, and so we just added a nurse that started working in our communication center 2 days ago. This has been a program we've been developing over the last number of years. It has been successfully executed in other jurisdictions and has had a major issue or major impact on some of the issues that we're facing. Andrew had alluded about the physician in the communication center. So paramedics always had access to a physician, but the physician might have been on call. November of last year, we started a new program where we actually put a physician in our communication center 24 hours a day, 7 days a week. When I talk about those 70% of those folks that may be low acuity, taking those people all directly to an already overcrowded and busy emergency department doesn't necessarily, it's not patient-centered, doesn't help them, doesn't help the other people in the system. That physician has the ability to put that person in a virtual waiting room, and then we check back when we can do it. So we're just really getting into this now. So in our communication center, we have some former paramedics. We have some lay people that have been trained to work in there. We have a very clinically competent paramedic who works a mixed practice in the communication center and out to provide support to the paramedics that are on the street. Also to help interpret and guide some of the clinical decisions that need to be made now with the nurse and the doctor that work together in the center. Some of the other initiatives that we have underway is that our system was built to have all of our patient transfers, and our paramedics do all the transfers and all the work basically. We're one of the few jurisdictions in Canada that didn't have a transfer service. So over the last year, we have really focused on taking and separating out our transfer service. The minister alluded to about laddering earlier. So we recognize there is a shortage of paramedics in Nova Scotia. There's a shortage of paramedics in Canada. There is a shortage of paramedics in the world. So we have to do things a bit differently. So about 40% of the work that we do are inter-facility transfers out of our call volume. We know that there are some patients that do require clinical care en route, but not all. And so a year ago in September, about 86% of all patient transfer movements that were done in the system were done by paramedics. And as of October this year, we're at 20% already. And I'm really pushing our team that we believe now that we have these resources in place that we can get that to 5%. So what does that mean? That means it increases a great deal of capacity in amongst our system for our emergency and urgent calls. The 30% of the patients that are sick, we want to make sure we're there for all the time. This is going to be we're starting to see this fundamental shift. Now we had a tough week in the EHS. We hit a milestone this week. We do about 560 calls a day. That's usually what happens. But a day earlier in the week, we hit 828 calls. So that's hard to keep up with. So the focus that we have on making sure that we provide the right practitioner to the right patient at the right time is key. And so this is what we will do. It's a big deal to make the changes that need to happen. I've described it like turning an aircraft carrier with a paddle, but we are making progress and heading in the right direction. So we'll continue to work on those things.
I just wanted to say that paying for the CCA education is a great idea. So good job on that. I have two questions, and I'm hoping I can ask one, get the answer, and then my follow-up may change. So my first question is, in other places across Canada, nursing staff, or I guess healthcare workers, were not mandated to have the vaccine. We were in a health crisis with needing it, so why did we mandate the vaccine?
So that was a decision, the mandates happened prior to us, but certainly we followed the advice of public health. And at the time, this is the path that the province chose, and we continue to follow that path. So the mandates were implemented as a way to protect and keep Nova Scotians safe.
Okay, so that helps with my follow-up question. So we mandate the vaccines, we get rid of the ones that don't want to be vaccinated. And then, if they go apply at the VON, they can work, unvaccinated, fill those unvaccinated positions for an extra $10 an hour plus travel expenses. I'm not seeing the common sense in this.
I can't speak to the VON. I really don't know.
You should check into it, because that's how it's unfolding.
I'm going to make a note. In terms of, I don't want to argue, that's for sure, but at the moment, the non-vaccinated healthcare workers are on leave of absence from NSH, and I think if you read the post today, you probably would have seen the numbers, which were current as of Monday. So in Nova Scotia, we have 127 healthcare workers who are not at work at this moment because they are not vaccinated, and another 7 at the IWK. So 127 at NSH on 26,000 employees, and 7 at the IWK. So there's no intent at this time to change that policy. I'm going to make a note and check on the VON. I really don't know the answer to that, so thank you.
I'm from Almadam, Richmond County. And we have a situation where we have 3 doctors, 2 of which are father and son, and they go on vacation. They've done this 3 different times. The last time for 10 days, we have no doctor coverage. I don't have a problem with them going father and son. What I have a problem with is why would the minister not provide a locum to the 3rd physician that has a defined license and could provide care for our community? I think that's a step that we need to take if we're going to solve problems for us anyway. The other thing that I would like to see is why would they not be required to have a replacement? Then at least we'd have coverage. My 3rd and most important one is, and I'm not sure if the gentleman was referring to this, why would we not implement the paramedic model where we have a nurse practitioner and paramedics that have access to a doctor, that St. Anne's Centre, for example, and Strait-Richmond could work together, which they don't, but they should, work together to try and provide services. The other thing is we have 2 doctors in Lardoise, 2 or 3, and maybe 4 in Port Hawkesbury, 3 in Arishat. We have at least 1 or 2 in the hospital in Strait-Richmond, serving 10,000 people roughly. Add to that 2 nurse practitioners, 1 which is not practicing, God knows why, she's not allowed. And there's no one available after 4 p.m. No one is doing home visits. No one on weekends. No emergency in Arishat or Strait-Richmond for at least, I think, 50% of the time. So we definitely have a problem there that could be solved by thinking out of the box. Also, I'm told, maybe I'm wrong, that the reason that the ambulances take so long to get to the person with an accident or whatever is because the beds in the Antigonish or Sydney are full of people who should actually be in St. Anne's Centre or that type of home. Now, if that's the case, we at St. Anne's are looking for a new build. We've been approved, as far as I know, and we're limited to 30 beds. It doesn't make any sense. Why not give us 35 or 40 beds? We have a list of how many? I think it's a 3.5-year waiting list. You know, so put the money in the project and get these people to have good health care and then turn around and the ambulances can come back. There was an accident with 2 young people next to my place, right next door. So I went out, I asked the girl, did anybody call an ambulance? Yep, 40 minutes, we'll have an ambulance. The ambulance came, 40 minutes on the dot. The 2 young people were on the cement, or the pave, I should say, laying down. Luckily, we had a nurse with the fire department that was really an asset. Now, the ambulance came, picked up 1 patient. The other patient was on the cement or pave for another 40 minutes. 80 minutes. There's something wrong. And I asked, well, what's the problem? Well, we don't have enough ambulance. And again, they told me that the hospital in Antigonish was overwhelmed with no beds. So the ambulance was parked there waiting. So if you really seriously want to solve the problem, those are the problems we need to address yesterday, not today. And we got to think out of the box. And you have to make a decision and be brave and say, this is what we need to do to solve the problems. So, anyway, my last thing, and I wrote them all down so you have them anyway, but, oh, yeah, this is a good one. No, it's even in New Brunswick, you know. You go to the doctor, you have 5 things that bother you. Doctor says, well, wait a minute. We got to give you the results of the blood test, but you got to make 4 more appointments to come back, and then we'll deal with each one. Now think about that. If the doctor took 15, 20 minutes, and I don't understand, maybe it's about the money, that's what people tell me, But if they had dealt with the 4 extra appointments, if they serve 1,000 a month, how many patients would be able to have a doctor now? You know, like I don't get it.
We're going to help you.
Good, I'm listening.
That may be the last question of the night because there's about 25 in there.
Yeah, I don't know what happened to the 3.
So I'm going to start. I'm just going to try and peel away parts of it, and I know between all of us we'll figure it out. So first, I want to talk a little bit about long-term care. So prior to being elected, I had the opportunity to work in long-term care, and one of the things that I'm very proud of is that when we were elected, we have a minister now of seniors in long-term care with a dedicated minister, dedicated staff, and dedicated funding, which is really important. So we know that there are a number of people sitting in hospital beds, living in hospitals, waiting to go to long-term care. We need more beds. And we've committed to that. And there are new builds that are happening across the province. We are trying to increase the number of beds. The other thing that was happening across the province was because there's an overwhelming lack of continuing care assistance. So there were actually empty beds throughout this province that we were not actually able to fill because we couldn't safely staff the beds. And I'll tell you, the people that work in long-term care are gifted. They are experts in working with frail elderly people and people who live with chronic diseases. And so one of the things that we did very early on in our tenure was increase the wages for continuing care assistants by 23%, which was significant because it pulled people, A, back into the profession, and B, it allowed people to see that as a viable career path for them, which is why when the deputy mentioned we went, like I don't know the numbers exactly, but I think in 2018, 2019, and you can help me, like maybe 6 people graduated from NSCC from the continuing care, and Annette needed them, and I needed them, and Carson needed them, everybody needed them. So now we have an enrollment in this province of 1,000 people, which is really going to help us open all of the beds. Also, we've worked with the province to make sure that we can train our own CCAs so that we have the workforce we need to support. And we also have committed to, as a government, increasing the hours of care, because when I worked at RK McDonald, they have a picture of the very first person that moved into RK McDonald, and he parked his car, he had a trench coat, and he came in with a black bag. Like, that isn't happening anymore. These are really frail folks. And so we've increased the hours of care that residents in long-term care facilities receive to 4.1 hours of care, and that's huge. So I do want to let you know that there's a lot of work happening in long-term care to strengthen that system and to make sure that the people who are in the hospital are able to get to skilled nursing facilities as they have before, and also working with long-term care. So during the pandemic, we didn't transfer very many residents to the hospital, right? Because of the pandemic planning, we needed to keep things. And so as organizations, we worked really hard with physicians and nurse practitioners to keep the residents there and give them the care they needed. And so that has continued to carry on, but we can do more there. And we can work with our paramedic colleagues to come in and offer special patient programs, and we can have them come in and do some interventions with those residents in order to keep them in their homes. So there is a lot of work happening, to your point, but it is going to take some time. Those buildings need to be built. In terms of the physicians, so the doctors that many of us had in this room that are my age and older, we had physicians that were seen they were paid by the patient, but they did everything. They delivered us, they did surgery sometimes, they did it all. They worked in Emerge, they worked in their offices, and physicians are trained a bit differently now, and I can't speak to the exact details of that. But those older doctors, our more mature doctors, are different than our novice physicians. And our older physicians might have had 3,000 patients, but now the newer physicians want to work in a team, and they want to have between 1,300 and 1,500 patients. So it almost sometimes is a nurse practitioner and a physician to one of our retirees. So it's just a different way of practicing because we're more complicated. We have more medications, we have more diseases, we have all kinds of different things as we age. So that's one of the things that we're working on. We're also giving doctors an opportunity to kind of choose the payment model that they want. So some doctors want to be paid by the patient, whereas others want to work on a salary. And so we're working around the accountability framework for that. So what are the number of patients that you would see in a day? And we would adjust it for the number of complicating factors that we have. So it isn't a replacement of one-to-one anymore, but we also didn't have nurse practitioners in the old days. And so we know that there's a workforce there that we can continue to grow. We know that we heard that through the tour that there were a lot of unemployed nurse practitioners. So Karen put something on her LinkedIn and got 50. So we know that there's latent capacity. So we do want to use all of our practitioners, like, you know, pharmacists and nurse practitioners can now work together in a model. We want everybody to use all of the skills and competencies that they had. So it is going to look a little bit different.
A few of the things you said is, you know, why aren't we doing this and why aren't we doing that? Which is, we are looking at everything. And I think that that's what's really important for people to understand, is it's not going to look the same as it always has. And so as we look at these new models, as we look at how people want to practice differently, you're going to have to be prepared that it's not going to look the same. But what we're working for is to make sure that you have access to the right care at the right time by the right practitioner. And so we all have to get our head around, though, that it is going to look different. It might be a different type of health home where you don't always see the same practitioner, but you might see the physician when you need to see them, or the nurse practitioner, or the dietitian, or the social worker, but we really want you to think outside the box with us, right? And think about, you know, are you getting care that is there when you need it? Is it ready when you need it? Is it reliable when you need it? And is it responsive to what your needs are? And that's really what we're working toward for you. But we do have to say that it is not going to always look the same as it has to date.
Yeah, I'd like to maybe pick up on 2 points. One, just kind of scope of practice. And actually, I had an opportunity to cross-examine Trevor Woodrow at dinner tonight. And, you know, Trevor is a chiropractor. Not a pharmacist, but your wife's a pharmacist. So just talking about, you know, the scope of practice of a chiropractor. So, you know, I got a one in Halifax. He's able to order an X-ray. But you can't do that all across Nova Scotia. Well, that's nuts. Like, that to me is nuts. Either do it or don't do it. So I don't know the answer. We got to find out. Right? Got to find out. Then we go to the pharmacist. So the good news about pharmacy is that through the pandemic, of course, you know, I think people were well able to see that the scope of practice for a pharmacist was a lot more than it was before the pandemic. And they have a whole lot more that they can do too, by law. So, you know, if you're an independent pharmacist, like Trevor's wife, Sarah, who I've not met yet, but I feel like I know her pretty well now, since I cross-examined poor Trevor. You know, she's a diabetic educator, and she in her pharmacy, she can pretty much set that up however she wants to set it up. So she can do the kinds of niche things that she wants to do. I go to a pharmacy in Halifax. It's Lawton's, and there's a home care in the pharmacy, which recently the pharmacists had to take over. So they're doing different things. They didn't really want to take over the home care part, but they did. And every time I go into my pharmacy, they say, "Oh my God, Karen, are you giving us more to do?" So we also have to be a little bit careful about that. But that's not us per se, that's also the employer. So, you know, pharmacists can do more, and we can choose many other healthcare providers, whether it's the physio, the OT, you know, name it, and everybody can do a little bit more. And the challenge, what we haven't done well in this province, is have people working to their full scope. So just think of the chain. You know, you got your CCA, your LPN, your RN, physician, you name it, OT, PT, pharmacist, paramedic, and so on and so forth. So if they're not working to their full scope, maybe we have this much. they're working to their full scope, all of a sudden we have this much that we are able to do with the same people. Okay? So we're working really hard on that because that's kind of a no-brainer. Now, one of the things that we're really interested in seeing how it all pans out after the hurricane, I'm going to say Katrina, but it was really Fiona. After the hurricane, we were very quickly able to put a mobile bus together. And we sent it down to, it was in Sydney. It was on Member 2 for 2, 3, 4 days, I think. And that bus is going to stay in operation this weekend. We actually have 2. One's in Digby and one's in Yarmouth. Last weekend, one was, they were in Kentville. They've been in Antigonish. I asked Trevor if he thought it would go well here. He thought it might. I hope you agree. So what we're able to do with the bus, though, is depending on which community, like different communities have different needs. It's not all the same. So you can put different providers on the bus to see what works. What group of people can see the most patients? What what mix is most effective? How do we make this work as effectively and efficiently as possible? So what we have found in, I don't know, 2 months or whatever it's been, we had the bus at Cobequid a couple of weeks ago. They took 126 people over 2 days, and those were folks that otherwise would have been in the ER at Cobequid. The same, no matter where we put it, there's many of the folks who otherwise would have been in the ER. And just understand, these aren't people who don't have a family doctor. In many cases, they have a doctor. They just can't get in to see their doctor. So we're able to do a little bit of what we call test and try. And so, these are the kinds of things that we're putting out there, we're trying. If it works, we do more of it. If it doesn't work, get rid of it and try the next thing. Like, we really are into almost an entrepreneurial mindset of seeing what will work for Nova Scotians. So, these are the I guess, innovations that they're not that hard to put together. And they're out, and they're on the road, and they're on the go.
Thanks for your questions and your comments, and they're all valid. And as a physician, I would like to address every one of them. The first one is, and you mentioned yourself, they deserve to go on vacation. Yes, they do. When I go on vacation, I go with my family. And the issue is, though, that I've been to that clinic, and July 1st and 4 o'clock in the afternoon, they're not with their family. They're probably in the clinic. They're taking care of people. They go above and beyond every day, so they need to take vacations. They are continually frustrated. They're calling me. We want to go on vacation. We need to go on vacation. We want them to take a vacation. We want them to recharge. We want them to be in a good state of mind when they come back. They simply can't find the help. And that's the issue. We simply can't find we talk about physicians and diagnostic imaging specialists, lab techs, physiotherapists, everybody. There's a severe shortage. We simply can't find those individuals to come in and fill in. What I've seen in the last year in the province has been a complete shift. There's a whole team, there's probably 16, 17 dedicated people to recruiting physicians, nurses, lab techs from the province, from all over the world, all over the country. It's completely changed, but despite that, we're still severely short here at Strait-Richmond. We're severely, severely short. We're working very hard to recruit people. We simply are not able to. We're competing against the rest of the country. I think we're, in the province, I'm comfortable that, we're saying we're recruiting. I do believe we're recruiting to the province. If we can recruit someone to Kentville, I'm happy. We're at a point, the 4 zones are getting along. We're not competing with each other. But unfortunately, we're competing with everybody else. So these doctors, that community, they're really stretched to find people to help. They need to go on vacation. They go on vacation. They're also private. They're private contractors. Nova Scotia Health does not control what they do. They can do what they want. They work hard. Your other issue was you got one problem. I'll see you for one problem. That's an interesting scenario, and it happens. I've seen it happen. I've heard it happen. I've lived it. And I do not believe in that, but guess what they say? When you go to Dr. Brian, you're going to wait 2 hours to see him. Why? Because he takes care of your problems. So do you want to wait 10 minutes or do you want to wait 2 hours? But the bottom line is that, you know, there's the philosophy amongst family doctors now that's not what they want to live by. I think they want to, there's a role, occasionally there's a role for that, but you know, I'll see you from one issue, but I do believe that they don't want to do that, but sometimes they're forced to do it, but it's not something they want to live by. And I think it's really something that we've progressed through because of the reason now there's more people, to Karen's point, there's more people able to do more. Everyone works to their scope of practice. More people can provide that service. And the final point is that, you know, I really haven't heard it in the last couple of meetings, is that I've been doing this for 25 years, and Minister Thompson mentioned, you know, they were these legendary doctors of 20 and 30 years ago, they were delivering babies. Guess what? There's not many babies being born now. The doctors now are looking after people who are 75 and 80 years old. And once you hit 75, their demands on the healthcare system completely change. And so these new doctors or the younger doctors, they're in a completely different environment. The technology is so much different. What I did 25 years ago is nowhere close to what I'm doing now. The technologies, the MRIs, the diagnostic imaging things we can do, robot, you can get your knee replacement done by robot now. And so the technology has changed. So these doctors are not practicing the same medicine that these doctors did from 30 years ago. So we have to appreciate that, understand that. But now we are thinking outside of the box, and we're introducing all these other individuals that can help with healthcare. And we're hoping that's going to spread the load some.
And that's where we'll wrap things up for this week's Telile 24/7. Thank you for tuning in, and we hope that you found the footage provided to us by the Department of Health and Wellness to be helpful and informative as we map out the next steps for healthcare here in the Strait area, but also all the way across Nova Scotia. If you'd like to comment on anything you've seen or heard over the past hour, or just simply to suggest ideas for future editions of Telile 24/7, feel free to contact me directly or contact Telile Community Television in Arichat. And be sure to follow Telile on social media. Don't forget, more footage from the December 2nd Community Consultation on Healthcare at the Port Hawkesbury Civic Centre is available on our sister program, Roundtable, and both this edition of Telile 24/7 and the new edition of Roundtable are available on our YouTube channel. I'm Adam Cook. Thank you for tuning in to Telile 24/7 this week. I look forward to seeing you again next week with a brand new show. Bye for now.